Thank you very much, and welcome to this webinar. We have jam-packed the agenda, as you notice here, and so each one of us will be speaking for a maximum of 10 minutes and speaking from the heart. Next slide, please. Modern medical education in India began under British rule, with the first medical college established in Mumbai in 1826, Madras in 1827, and Calcutta in 1838. From 1947 to 2025, the medical colleges in India have increased from 20 to 702. MBBS seats have increased from less than 1,000 then to over 100,000 now. The All India Institute of Medical Sciences was established in New Delhi in 1956 by an Act of Parliament as an autonomous institution of national importance. The foundation stone was laid in 1952, and AIIMS New Delhi began operation in 1956. At present, 24 AIIMS are functioning and 6 are under planning. In 2019, the National Medical Commission Act was introduced to improve quality of education. Professor Sneh Bhargava is an eminent and much decorated radiologist. After completing her postgraduate education in radiology from UK, she joined AIIMS and became the director of AIIMS in 1984. During her tenure, she undertook many new and significant initiatives. One of the significant initiatives was to train nearly 30 faculty members in medical education and set up the KL Vig Medical Education Center under Professor Usha Nair. One of the mandate of AIIMS have been to make India self-sufficient in postgraduate medical teaching, and to produce teachers who will train MBBS doctors to work in India and to fulfill the medical needs. We are fortunate to have Professor Sneh Bhargava to chair this meeting, and now we'll hear from her. Professor Sneh Bhargava, please.
Thank you very much for giving me this opportunity to chair a very important subject which is close to my heart. That is education, and through education, producing manpower to look after not only the healthcare needs of the community, but also I draw a distinction between healthcare and medical care of the community. The subject that you have chosen, recalibration of medical education, has been far long overdue. The reason why I say so is that our education has really been, of course, derived from what the British put in, and the report that the British gave before they left was that we should have primary, secondary, and tertiary education structures, verticals. But the government of India did not follow these strictly. What I am very sure about is that we have been emphasizing more on educating for treatment of health and medical health care, but have really neglected the preventive and the promotive aspects of healthcare. So my very strong opinion is that we need to emphasize on preventive, promotive healthcare, and therefore what you can call primary health care, and then go ahead after that. What I have read recently in the media by figures by the Director General or Deputy Director General of Health Services is that we have 780 medical colleges in the country, and we produce 1.2 lakh graduates every year. This is the highest figure of producing medical manpower in the world. And if you look at the ratio between doctor to patient ratio, it works out to be better than what the WHO really dictates. So, as far as manpower numbers are concerned, we are producing enough number of medical graduates. But where are we going wrong? So that our healthcare statistics show that we are worse than sub Saharan Africa. Why is it? We need to think about this as to why we are not having the results that we should be having. If at this stage you want to ask me any question, I'm ready to answer and then I'll go ahead.
Ma'am, so how would you suggest we address the problem?
Do you agree with this first?
Yes, ma'am.
The first thing is that we must be able to reach our population 1.4 billion, and to reach the furthest corner of the country, we have technology now, which was not available years ago, even during the time that I was at AIMS, and was very conscious of the fact that that my predecessor, Dr. H.D. Tandon, had done a survey of the teachers at AIMS, and he had asked the students to grade the teachers. And in that, the data that came out was that not all good doctors are good teachers. So that made me realize that we ought to be able to uh, give more stress on our trainers. Unless our trainers are trained, how can they train other people? So, therefore, we started the Center for Medical Education. At that time, Professor Wig had donated rupees 1 lakh to the institute to be used wherever it is required, and I decided that it was going to be used best in a section that we would start, that is medical education. And for that, I had decided that since we do not have enough trainers for our trainers, then I approached the British Council to advise us as to where in the United Kingdom we could send our staff to be trained. And they had suggested the Dundee Institute of Medical Education, to which I sent 44 faculty members, starting from professors, middle grade, and newly joined teachers. So that set up the Center for Medical Education, and Usha Nair and Kusam Verma helped me in organizing this. After that, we have been talking to all uh, central government supported institutions to start off centers of medical education in every medical college, because not all good doctors are good teachers. So that is our first effort, that we ought to have first enough teachers. When Rajkumari Amrit Kaur, the first health minister of the country asked the 17 medical colleges that were present at the time of independence as to why they are not producing enough teachers, the answers they got was that we do not have enough teachers. Therefore, the when she put the act to Parliament while establishing aims, she said our responsibility will be to train teachers. And of course, in the teachers, she specified that we would train postgraduate teachers, specialty teachers, as well as our responsibility will be research and patient care as the last. Unfortunately, because of the volume of our population at that point in time, demanded more patient care than teaching care, a lot of our faculties, brains, and times went towards patient care. And the teaching part at that time had been neglected, which I tried to correct at that point in time. Now you will ask me, why are we behind? Our statistics in healthcare are so poor? The reason is this, that primary and promotive healthcare have not had a special structural cadre to which they will rise as compared to the specialist cadre. So the result is that we do not have enough of what I call now, you can call, or they were always called, family medicine specialists. We need to have a, a whole lot, far larger number of family care physicians than we have of secondary care and tertiary care physicians. Unless our base of primary health care physicians is strong, our figures, our statistics will never improve. And today, with the help of technology, with telemedicine, you can reach the farthest corners of the country by training people in primary health care, which does not require an ultrasound, an X-ray, or a CT or an MR. These are the people we ought to train primarily first. So this is my very considered opinion that we must raise the stature of the primary healthcare physician to that of the specialist, so that people are encouraged to join primary health care, where you will examine a patient from head to toe. And only then, when you are satisfied that you cannot handle a particular patient from head to toe, then you should be referring this patient to the specialist, whether at the secondary level or at the tertiary level. I think that it is necessary that we follow the National Health Service of England, where people cannot approach a specialist without going through a primary health care physician. Only if your primary health care physician thinks that you require secondary or tertiary health care, you should then only secondary and tertiary healthcare physicians should come into the picture. How do we do this? What is the cause of our poor statistics? Is that we need to have data analysis of our death rates and in what diseases. Data analysts should be able to tell us what type of physicians we require and the numbers. at the primary level, secondary level, and tertiary level. Now, unless we have that data, our curriculum cannot be reorganized because we follow a curriculum that has been set years ago with, with slight modifications. But we need to have a data analysis of what our diseases are and what sort of physicians we require to treat these diseases and bring down death rates. So, my very strong suggestion is that we need to have a data analysis. Now, in our structure of the healthcare system, medical education is a central subject, but health care is a state subject. So all, excuse me, the states have to be able to feed the data of their illnesses to the center. Unless we have the states as active as the center, we cannot go ahead. So this, and I know because I have sat on committees of the Medical Council of India that the communication with the center and the states is far from what it should be. Some states never respond to letters sent by the Central Health Authority. So, and we know, for instance, that the southern states have done far better than the north and eastern states. The southern and the western states have done much more. And the tragedy is that the the figures, national figures that we produce of either diseases or deaths is a combination of the North and the South. The result is the good work done by the southern states is hidden, and so is the poor work done by the northern and eastern states also hidden, to give you a national figure. So, better communication, and with today's technology, there is no reason why we cannot have better communication between the center and the states, and the center can impress upon the states the necessity of feeding proper data. So, data analysis, a lot of your graduates should go into data analysis so we have data first on which we can act. So, this is my very strong opinion, and I hope you will share it and others would give thought to this before we produce high quality specialists. I am not for a moment saying that we do not require high quality super specialists. We require them, but their need has to be graduated according to the diseases we have and according to the numbers that need to go to a specialist. We know in everyday practice, anyone who has a backache goes straight to an orthopedic surgeon or to a neurosurgeon. They do not go to the primary health care physician because we have not created that system. Unless we make that structural change in our healthcare system, everyone who thinks they have a backache will go to an orthopedic surgeon and a neurosurgeon. And when they go there, what do you expect? An orthopedic surgeon will get the usual technology investigations done, which may include an MRI. The neurosurgeon certainly will get an MRI done because that is what he has been trained for. So I strongly believe we need to strengthen primary health care, and our trainers must emphasize on the 3 P's: primary health care, preventive health care, and promotive health care. The bulk of our graduates must fall into this category and then gradually rise to secondary health care and tertiary health care. Though I have run AIMS, the Center of Higher Education in Medical Health Care, my strong opinion has been that unless we do strengthen primary health care, put enough of our funds into primary health care, we will not be able to improve the health or the medical care status of the patients. Patients must understand it is their primary job to look after their own bodies. And we must start this as children are in school, to look after their own bodies and subsequently go ahead with whatever functions they decide to do.
Thank you very much, ma'am. We would soon roll out what we've been working on, that is to take medicine to the last mile. And I think Caho will indicate in a few months what we plan to do. Thank you very much. We take your advice with great sincerity, and hopefully soon we will show that yes, we've been working on it. Now,
All right, I'd be keen to hear what you have done and see if I can add to that.
thank you very much, ma'am.
Okay. Thank you.